Hi, everyone. I'm Vasilia Vastis. I'm one of the PGY4 residents in obstetrics and gynecology here at McMaster University. And thank you for allowing me to present today. So my project is entitled Impact of Protocol Adjustments Due to the COVID-19 Pandemic on Infertility Treatment Outcomes. I'd like to thank my colleagues and my supervisors at One Fertility in Burlington, Dr. Sophia Husseini, Michael Neal, Dr. Megan Karnas, Dr. Turk, Dr. Min, Dr. Denise, and Dr. Faji as well. So we'll start with just a brief introduction and then go on to discuss the objectives, methodology, results, and conclusion of the study. So the COVID-19 pandemic has impacted many different domains of the healthcare system. There are roughly 2.5 million IVF cycles globally being performed every year, resulting in over 500,000 deliveries annually. As of March 2020, the CFS, the American Society for Reproductive Medicine, as well as the European Society, including other international professional bodies, all recommended that ART, which is assisted reproductive technology, should stop to prevent overburdening the healthcare system. It's also important to note that infertility services were deemed non-essential, which in part is one of the reasons that fertility clinics shut down. Specifically in Ontario, to implement health and safety considerations and recommendations from the CPSO guidelines and the Ministry of Health's COVID-19 operational requirements, multiple changes were made in treatment protocols and in patient care at One Fertility. So the operational changes that were made included fewer in-person visits, fewer ultrasounds, fewer laboratory investigations, as well as really no face-to-face instructions on what to do. It's also important to note that the female age is a critical variable when treating infertility. Advancing maternal age from the age of 34 years of age or those with a reduced ovarian reserve make up most of the infertile population, whose chances of achieving a live birth decrease with time. So in these women, temporary shutdown of IVF for an indefinite period is thought to cause a reduction in IVF births as well. So the purpose of this study was to evaluate and compare pregnancy rates among patients who had ovarian stimulation with intrauterine insemination and frozen embryo transfers prior to the pandemic with those who were treated during the COVID-19 pandemic to understand if this temporary shutdown and newly developed protocols affected their overall success. So moving on to the methods of this project, this was a retrospective cohort study. Patients in this study who underwent IUI, IVF, and FET, frozen embryo transfers at One Fertility, were divided into two groups. The first group was the pre-pandemic group, and these were patients that were treated between June and December of 2019. The second group was the pandemic group, and these patients were treated from June to December 2020. The primary outcome for our project was clinical pregnancy rate, which we defined as the presence of a gestational sac on ultrasound and fetal heart on ultrasound at about 6 to 7 weeks gestational age. It's important to note that IVF cycles were freeze-all and they were not included in the primary outcome. And this was because during the COVID pandemic, we weren't able to do fresh embryo transfers. The secondary outcomes were biochemical pregnancy rate. So this is when we have a positive serum beta HCG 12 to 14 days post the procedure from IUI or FET, as well as the number of eggs retrieved and the fertilization rate from the IVF cycles. So the protocol adjustments that were made during the pandemic are listed here. So first, to start with in-person visits. Pre-pandemic, every new patient was referred to One Fertility underwent diagnostic cycle monitoring. This involves a series of blood tests and ultrasounds to monitor one menstrual cycle. During the pandemic, however, diagnostic cycle monitoring essentially stopped. We stopped doing this for all patients, as well as timed intercourse cycles stopped as well. Moving on to ultrasounds. So with the decrease in patient visits came the decrease in the number of ultrasounds that we were doing for cycle monitoring, as well with laboratory investigations and semen collection. This also decreased. So in regards to the semen collection, we didn't actually collect data on whether or not the collection was done in the clinic or versus home. If it was a home collection, the patients were asked to provide the semen sample within 1 hour of the collection, just to ensure adequate processing. As well with face-to-face instructions. So this was substituted with online IVF e-modules that were created by the staff at One Fertility. They were sent to all patients by email and were were required to be completed prior to starting an IVF cycle. All consents were done over the phone and all forms were signed by DocuSign. So briefly, kind of going through these protocols. So we'll talk about IUI, IVF, and FET protocols. So before the pandemic, patients would call on cycle day 1. For letrozole and IUI, that's just one of our protocols for stimulating eggs, essentially. They would be seen on cycle day 10 to monitor they would be seen on cycle day 10 to monitor follicular growth by doing an ultrasound and blood level, looking at the estrogen and LH level. If their follicle was less than 15 millimeters, they would essentially come to the clinic every day or every 2 days to have an ultrasound and hormone check. If we found, or once we found that their follicle was greater than 15 millimeters and they were ready for a trigger, they would come in for another ultrasound and blood work the following day. Essentially, the clinic would schedule the IUIs based on the LH surge because we wanted to catch them before ovulation, or ovidral trigger, which essentially triggers ovulation. Once the follicle was a good size at about 20 millimeters. And once we had also confirmed that the lining of the uterus was good and the estrogen level was appropriate. For patients who underwent the FSH and IUI protocol, that's just a higher dose of medication to stimulate more eggs. Blood work and ultrasound would be done on cycle day 3 and day 8. The rest of the monitoring was the same as the letrozole and IUI cycle. During the pandemic, the number of visits were significantly reduced. For the letrozole and IUI cycles, patients were seen just for the first time on cycle day 10. We knew it was cycle day 10 because we instructed them to call when their period started on cycle day 1. Patients were provided information about their ovidral injection or their progesterone suppositories, as well as something called an OPK, so an ovulatory predictor kit. It's just essentially a stick that you urinate on and it tells you when you ovulate, as well as a collection cup for sperm samples to be done at home. Patients were then instructed to call the clinic once they had a positive OPK, this meaning that they're ovulating. However, in some patients, like patients with PCOS, this is not accurate. So once they had a positive OPK, they would take their ovidral shot, which essentially triggers ovulation, and then their insemination would be for the following day. The morning of the IUI, the sperm sample, typically we think, just from talking to patients, most of the sperm collection was done at home. So we would just ensure that they provided it within 1 hour. If there was no positive OPK by cycle day 20, the patient was instructed to come in for an ultrasound and blood work to see maybe we missed the ovulation or maybe they haven't really grown any follicles. For the FSH and IUI cycles, patients had blood work on cycle day 3, and they were all given the required information as above about that cycle and about that visit. The next visit was cycle day 10, and similarly, once those patients had a positive OPK, insemination was booked for the next day. For the FSH group, they were just monitored a little bit closer because there's a risk of multiple follicles and then a twin pregnancy because it's a higher medication. So that was really the only reason for that. Looking at the IVF cycles, so before the pandemic, the patients would call on day 1. And as mentioned before, cycle day 1 is the first day that the period starts. And they would schedule to start the IVF process on cycle day 3. Blood work and ultrasound would also be done on day 6, 7, and 8. Once the follicles were greater than 15 millimeters, and we use 15 because essentially that means they're mature, patients would come in for daily blood work and ultrasound until they were ready for their ovidral trigger shot. During the pandemic, blood work and ultrasound were done on cycle day 3, 8, 10, and 12, and the trigger shot was done at home. And then moving on to frozen embryo transfers, like I mentioned before, we didn't do any IVF cycles with fresh embryo transfers, so those were excluded from the study. So for FETs, this was similar pre and post-pandemic actually. So in the pre-pandemic group, patients called on cycle day 1, they booked their blood work and ultrasound for day 10, and then continuous monitoring with blood work and ultrasound was done essentially every single day until the lining of the uterus was appropriate to do the transfer. During the pandemic, patients would only attend clinic on cycle day 10 for blood work and ultrasound, and then they were at home for the rest of the time, just doing an OPK test every single day until it told them that they were ovulating. And once that was positive, the transfer would be scheduled. So moving on to the results. So first looking at the insemination. So the patient characteristics that we captured were BMI, duration of infertility, the number of dominant follicles. Here we actually used greater than 15 millimeters. They were actually similar between both groups. The total motile count of sperms in the IUI sample was actually higher in the pre-pandemic with a mean of 56.5 million compared to 32.5 million. Patients' AMH, so anti-Müllerian hormone, a measure of kind of their ovarian reserve, was a little higher in the pre-pandemic group with a mean of 18.9 compared to 14.1, a lower number is a worse AMH. However, this result was actually not statistically significant. Looking at our objectives and our primary outcomes, the IUI clinical pregnancy rate in the pre-pandemic group was 12.3% versus the pandemic group, which was 11.7%. And the biochemical pregnancy rate in the pre-pandemic group was 14.4 versus in the pandemic, it was 13.1. These were actually not statistically different between the pre and pandemic group, which was reassuring. Moving on to IVF. So the average patient's age was actually higher in the pandemic group, and they actually had a slightly higher estrogen level as well on the day when they booked the egg retrieval. When we compare both of the groups, there was a higher egg maturity, a greater number of eggs injected with sperm, and better fertilization rate, and a higher number of cleaved embryos in the pandemic group versus the pre-pandemic group. Despite this, the blastocyst development rate was not different between both groups. The AMH level was actually slightly higher in the pandemic group at 16.5 versus 14 in the pre-pandemic group, but these results were not statistically significant. Additionally, the total dose of FSH was similar in both groups. And once again, we didn't look at pregnancy rates with IVF fresh. Looking at the frozen embryo transfer, so the baseline characteristics were similar in both groups as were the other groups. The average age in the pre-pandemic group was 36.2 compared to 35.8. The AMH level and the number of embryo transfers were also similar between both groups, but this was not statistically significant. The clinical pregnancy rate and the biochemical pregnancy rate was also not statistically different between both of these groups. The embryos in the pre-pandemic group, as I mentioned before, were June 2018 to December 2019, and then the embryos in the pandemic group were created between June 2020 to December 2020. So this is also another limitation, because just because these embryos were created then, it doesn't mean that they were transferred then, or that the IVF cycle was then as well, because they were frozen. So moving on to limitations of this study. So our sample size was small, and it's not very representative of the general population in Ontario or Canada or other clinics really. As mentioned, all of the IVF cycles were freeze-all, so we can't really comment on pregnancy rates for fresh transfer after a cycle of IVF. We didn't record sperm collection sites, and we also did not collect patient and staff perception on the effects of different protocols that they could have. We assume that the patients wouldn't really be happy not coming into the clinic as often, not seeing the physicians and nurses as often as before, but we didn't collect that information. So in conclusion, the treatment protocol adjustments due to the COVID-19 pandemic did not adversely affect IUI, IVF, or FET outcomes at one fertility. Interestingly, the fertilization rate was better and the number of cleaved embryos were higher in patients who had IVF treatment during the pandemic. It is reassuring to know that the pandemic protocol adjustments did not have a negative impact on these patients' infertility treatment outcomes, and allows us to potentially keep these protocols in place. Thank you very much. I'll take any questions.